This is Mark Lichty. I'd like to welcome you. I'm chairman of Active Surveillance Patients International. I'm here as a representative for a coalition of groups that has created these webinars to guide men through the active surveillance process. I'd like to welcome Dr. Lawrence Klotz, who is really the father of active surveillance, perhaps in the world, and also Larry and Nancy White. Larry is a patient, Nancy is his partner, and they're here to discuss the issue of Larry's rising PSA. With that, I'd like to get rolling on the webinar.
Mr. White, I'm Dr. Klotz. Nice to meet you.
Very nice to meet you.
I see you're here with your better half.
That's right. Nancy has joined me. We're trying to figure out this process together as a family. And she's the better part of this group and has done tremendous amounts of research on prostate cancer, probably more than I have. And, we have some questions that we have written down and so we don't forget. And we also wonder if it would be possible if we could record the sessions. So once we get home, we can kind of listen to it as we begin to take your advice and everything. Sure.
By all means, and it's good to have a second pair of ears to listen to the story. Let me just ask you a few questions. You're in good health generally?
Generally, I do have high blood pressure that's well controlled. Otherwise I'm pretty healthy.
And how old are you now?
I'm 70 at this time.
And do you have a family history of prostate cancer?
I do. My dad had prostate cancer and probably died secondary to prostate cancer, but I'm not sure about that.
Around what age?
He died at about 74, developed prostate cancer in his late 60s.
Okay. And have you got any symptoms as far as urinating?
No.
All right. And this is really about your elevated PSA. So I gather your PSA was elevated recently. Do you know the value?
Recently, the most recent one was 6, and that's what kind of precipitated this visit. But because my dad had prostate cancer, we've been taking it periodically, and we've watched it kind of go from 2 to on up to 6 over the course of a few years.
Okay. So would you know what it was, say, a year or two ago?
Yeah, I don't at this time. I'd have to look at my records and find that out.
Okay. I see you've got some questions. Do you want to start with questions about where you'd like to go with this?
Well, I guess my main concern is my PSA has gone up.
Right.
And perhaps more rapidly than Dr. Span thought was reasonable.
Yes. Okay. Fair enough.
And so the PSA is one issue, but he introduced us to active surveillance. So I guess we're trying to figure out, am I a candidate for active surveillance, but really, do I have prostate cancer? He wanted me to come to you as someone that's going to be able to hopefully help us figure out diagnostically what's going on and what might be the best course of action for my treatment.
So, and I gather from your family doctor that the examination of your prostate was normal.
Correct.
So your major risk factor is your family history and your PSA. The PSA does go up with age normally as the prostate gets bigger, which is kind of a normal male phenomenon. And yours is really borderline for your age. In the 60s, the upper limit of normal is around 4.5. When you reach 70, it goes up to around 6.5. So yours is kind of at the upper limit. And with your positive family history, and particularly with your father actually succumbing to the disease at a relatively young age, you certainly have a kind of moderate risk of prostate cancer. And we can run the numbers on an online nomogram, but my estimate, given those various parameters, is that you have roughly about a 15 to 20% chance of having a significant prostate cancer, and probably another 15 or 20% chance of having a what's called a clinically insignificant or a low-grade prostate cancer. So yes, the first step is to make a diagnosis. The discussion about active surveillance really comes once we know what you have.
Right.
And, if you have one of the favorable low-grade types, or even one of the kind of borderline intermediate types, active surveillance, definitely an option, but we have to get there first. If you have a high-grade cancer, active surveillance is not a good strategy. You need something done.
Okay.
So the next question is, how do we make the diagnosis? This whole area has shifted considerably just over the last few years. Historically, you would have been subject to what's called a systematic biopsy, which usually means 12 needles poked 12 times from your rectum into your prostate. So this has now changed dramatically. First of all, we usually image the prostate before doing the biopsy. So the next step would be for you to have an MRI of your prostate, and some places, including myself, are now using a new technology called high resolution micro ultrasound.
Okay.
Both of those are very sensitive for picking up significant cancers. So if you're game, we'll put this into gear, we'll see what it shows, and then we'll have a discussion about what to do next. And basically I would say, if your imaging shows, the term is a region of interest, which really means an area that is suspicious for significant prostate cancer. If it shows that, then we proceed to a targeted biopsy where we just put needles into that lesion. So that's the plan. We'll arrange the imaging and we'll take it from there.
Okay. I'm a little bit anxious about the whole thing. I mean, how accurate is the MRI or the ultrasound, and are they diagnostic in and of themselves?
So at the moment, the only way to diagnose prostate cancer with complete certainty is with a biopsy.
Okay.
That may be changing. And that in part because of another test called a PSMA PET scan, which is still not that widely available in most places in North America at the diagnostic stage. It's more available at once a patient has actually been diagnosed and even treated for recurrence. So in 2022, we still 100% rely on the biopsy. And there's two reasons for that, or maybe even more. One is that not everything you see on the MRI turns out to be cancer. And particularly the MRI, and both the MRI and the micro ultrasound are graded from 1 to 5 for the reading of 5, which means very, very suspicious. Around 80% of patients will turn out to have significant cancer. It's still not 100. Okay. At a reading of 4, it's a higher proportion, about a third or more don't have prostate cancer as far as we can tell. So you can't simply rely on the image to tell you for sure that there's cancer. The other piece of this is that the pathology itself very much drives the treatment decision beyond just whether or not you have prostate cancer. And without going into too much detail, that is also now graded from 1 to 5. It's called the grade grouping, and they are like night and day. Grade group 1 is so indolent and benign acting, it's not really a cancer the way people think of it. We usually don't treat it. That's the basis for active surveillance. Grade group 5 at the other end of the spectrum is almost always lethal. That's rare. And then there's a whole range in between. So there's a tremendous amount of information from the biopsy that goes beyond just whether or not cancer is present.
Well, on the MRI of the prostate, I've been reading about that, and I was wondering, will a contrast agent be necessary? I read that
yes,
gadolinium can cause can breach the blood-brain barrier and cause some syndromes?
So the first thing I would say is, first of all, it's a very good question. The
I
second
told you
is,
he had been reading about this.
the second, gadolinium is safe. Gadolinium is widely used. Anytime a patient has an MRI, the gadolinium most of the time is administered. It improves the amount of information you get from the MRI substantially. We still use it very routinely. Now, for the average patient having an MRI for diagnosis, in your case, for example, it actually doesn't add all that much. What it does add is very good information about the actual extent and location of the cancer. To what degree is it infiltrating into the capsule, for example? So in a sense, you're not there yet, right? We don't even have a diagnosis. And there's an increasingly people in the field are asking, can we dispense with the gadolinium in patients like you, where we're not so much interested in the precise delineation of the cancer. It's really, is it there or not? Is there something to target? So the reasons to drop the gadolinium are basically related to cost, because it does add some cost, and also to the relatively uncommon risk of side effects. I must say at this point, I'm still kind of agnostic about this. I think it does add something, but it's probably not essential for the majority of patients. It probably does reduce the accuracy of the MRI, the sensitivity to some degree. So if you have a strong preference, we could drop the gadolinium, but my advice at this point is that you would have what's called multi-parametric MRI, of which the gadolinium is one of the three, is necessary for one of the three parameters we use.
Well, that's good information. At what point does the biopsy fit in here? I mean, is it if we have a positive MRI or the ultrasound, then?
Right. Yeah.
Okay.
So first of all, let me just address what we do if your imaging is negative.
Okay.
So the imaging is not 100% accurate, but the metric that we use is called the negative predictive value. In other words, if it's negative, what is the likelihood that you don't have anything significant? And the negative predictive value for both of these imaging modalities is around 85% to 90%. So what that means is if the best estimate of your risk of having something significant is, say, 20% based on the parameters that we talked about, it's just simple arithmetic. A negative imaging study means that your risk drops 85 to 90% from 20 to around 2%. Okay. In a guy your age, or just in general, a 2% risk is not something to take seriously. You know,
Okay.
100% confidence you don't get in medicine.
Right.
To get 98% is pretty damn good. So in a case like yours, my strategy would be, if the imaging was negative, not to pursue it any further. Now and we would probably we would definitely follow your PSA. If it continues to rise, the question can be revisited, probably another imaging study in 2 or 3 years, that kind of thing. The alternative is to do the biopsy regardless. So that would be the traditional 12-core systematic biopsy, because there's no target. And that would be warranted if you were at higher risk. Let's say your PSA was 20, and particularly if you had other risk factors, you've got the family history. The other risk factor, of course, is race, or African American or Canadian, or if your prostate feels suspicious. So if you had some other risk factors plus a higher PSA that put your risk more in the range of 40 to 50%, then negative imaging is not enough, and you still have to proceed with the systematic biopsies. But increasingly, at least for me, it's really about targeted biopsy. No one wants to have multiple cores if they can avoid it. And the other thing I would say is there's some evidence that the cancers that are missed with imaging are also likely more favorable cancers. They're probably smaller. They are also, the evidence is suggesting, biologically less aggressive. So in other words, the downside of missing a small cancer that was, of not diagnosing it because it wasn't seen on the imaging, is probably, in the vast majority of cases, not very serious, and therefore you can follow the patient and everyone is happy not to have a biopsy.
Yeah.
Okay. So that's one scenario. On the other hand, if your imaging shows a significant significant region of interest, not yet a cancer, but a region of interest, and that would be on MRI, what's called PIRADS 4 or 5, a grade 4 or 5 out of 5. Grade 1 and 2 basically is favorable. In other words, it means your likelihood of something is very low. Grade 3 doesn't really move the needle one way or the other. It's completely equivocal. So we're really talking about a PIRADS 4 or 5. Then you would go on to have the targeted biopsy, and whether the rest of your prostate is also assayed really depends on your underlying risk. In my practice, I would say about 80% of patients only get the targeted biopsy nowadays. And then we follow the rest. So the next question that, not to preempt you, but the next issue is how the biopsy is done. So this is also,
Right.
this has also evolved quite recently. So traditionally, this was called a transrectal biopsy. And the appeal of that is the prostate is sitting right adjacent to the rectum. You put the probe in the rectum, the needle goes through the probe, through the rectal tissue right into the prostate. And it's very accessible. It's very easy to anesthetize the area with local freezing. And that's how it's been done for basically 40 years.
And that's what most of my friends have had done that have had.
Right. So there's a problem though. And the problem is you're taking a needle and you're inserting it from basically a very non-sterile location, which is the rectum, where there's poop, and you're injecting it through that into the prostate, which is normally sterile. And you do it with preventative antibiotics, with an enema to clean out the rectum. But despite best efforts, a small proportion of patients, and depending on which series it is, somewhere between 1% and 4% of patients having that procedure get an infection. And the infection can be quite severe. And they also can have bleeding because the blood supply in that area is very, very robust. And so for those reasons, and I should also add, there is a mortality rate from that infection. It's very low, but it's not zero. And every one of those cases is a catastrophe. It's probably somewhere between 1 in 1,000 to 1 in 10,000. But you consider in the United States, there's about a million biopsies done a year. You're talking about a lot of patients nationwide.
Right.
So for those reasons, there has been a switch in many people's practice. I am one of them. I've completely switched to what's called transperineal technique. So the ultrasound device still goes up the rectum, but the needle goes through the skin in what's called the perineum, which is the skin just between the scrotum, the back of the scrotum, and the anus. And that is, you sterilize that area. The needle goes in sterilely. There's essentially no risk of infection. There's very, very low rate of bleeding. It's safer. And in my opinion, it's a better way to do it. So I think this is really a shift. It takes a while to change practice, but that is definitely the way people in the field are moving. Now there's, with everything, there's there's a benefit and a downside. The downside is it's a little harder to get good anesthesia. Patients do seem to feel it a bit more. And also the needle has to travel further to get to the prostate. So you have to, you need a little bit of extra equipment to make sure the needle is lined up properly and doesn't get deflected one way or the other. So there's kind of some additional skill sets involved, but really, in my opinion, there's no looking back. It's unequivocally a safer way to do it. And my prediction is that within another 4 or 5 years, no one will still be doing the transrectal strategy. So if you just had your imaging, there's a lesion there, we would, under normal circumstances, plan this transperineal biopsy.
Is the transperineal biopsy more accurate, or can you find cancers maybe that you wouldn't even find in the transrectal? Or
yeah, so the many people have looked at this. Basically, the diagnosis rate is the same.
Okay.
It's the appeal of it is more the safety than the accuracy. Okay. There are parts of the prostate, so you can imagine the prostate sits on top of the rectum. Most prostate cancers, but not all, but about 70% occur in the back part of the prostate, right next to the rectum. So that's very easy to access either way, probably even a little easier with the transrectal approach. But the so-called anterior cancers, the cancers that are at the front part of the prostate, close to the pubic bone, those are more readily evaluated with the transperineal technique. So that part, there are some advantages with respect to location.
Okay.
So I've heard about liquid biopsies too. Is that happening yet? Is it?
So this refers, yeah. So this refers, it's a bit of a misnomer. A biopsy means tissue.
Okay.
Oh yeah.
So but liquid biopsy refers to using molecular genetic tests to identify the presence or absence of cancer. There's a whole slew of them. There's about 5 or 6 that are now commercially available, and they're basically blood or urine tests. And they have a role in trying to stratify patient according to risk. So, I mean, an option for you would be to have one of these tests. If it's very favorable, then you might, particularly if your MRI was negative, that would provide further support to conservative management not going ahead with the biopsy. They're emerging. I would say as of today, it's still not that common to do one of these tests before moving on to the imaging. But that may change. It's partly related to the cost of the tests. They cost somewhere around $500 to $900. And keep in mind, they're not a diagnosis. What they do is risk stratify. So they would tell you, okay, based on your various parameters, including this molecular genetic test, you have, say, a 5% chance of significant cancer or a 50% chance, and then you still have to make a decision. So you could certainly have one of these tests, and it might, that's another strategy to move forward. If it was very favorable, you might not have to have the imaging. They really are two, at this point, it's kind of 6 of one, half a dozen of the other, whether you go with the imaging first or the assay first. In regions where the imaging is widely available and also where it's not that expensive, because most of the time the imaging and the molecular test are in the same ballpark in terms of cost, around $1,000 plus or minus. There's at the moment, I would say it's somewhat of a preference to go with the imaging, which also tells us about location, size, grade, because the higher the grade of the image, the more likely the cancer is to be higher grade, and so on. So So my recommendation right now is to go ahead with the imaging.
Well, I mean, I have been smiling during our interview, but it's mainly due to anxiety. So because of my dad's situation, and of course I kind of watched that process go on and such. And my preference, I think, is to take the most definitive approach to diagnosing this. And we've kind of discussed this as well, and you've answered really all of our questions pretty darn well. But I really do want to take the most definitive approach, I think.
Right. So I would say the next step is we'll put the MRI into gear, and we'll see what we come up with. So what I normally do is once I get the MRI report, I'll give you a call, and we can decide whether to go ahead with the biopsy if there is something on your MRI. If there's nothing on your MRI, if it's negative, you may elect to go the route of one of these molecular tests, just to really consolidate the fact that despite your family history and the rise in PSA, that you really have a very low risk of having significant cancer. And those, just to be a little more granular, the molecular test, there's one called the 4K test, the PHI test, the MIPS test. There's a whole series of them. They all, in my opinion, perform around the same, and we can kind of cross that bridge depending on what your MRI shows.
Okay, well, that sounds reasonable, you
Sounds
think?
great.
Okay.
Mm-hmm.
All right. So it's been a pleasure talking to you, and we'll get the ball rolling.
Thank you so much.
Thank you.
Well, what a story that was. And thank you so much, Dr. Klotz. You have showed tremendous courage, because I know when you first got into the active surveillance world, it was not a popular world to be in. And so we admire you and respect your courage in taking a leadership role. All of the participants today were volunteers, no compensation. We have no budget. Larry and Nancy, great job. And behind the scenes, you didn't see Phil Siegel and Howard Walensky, but they've been driving forces in creating this piece. And Alex and Peter, Alex Schultz and Peter Schultz, thank you so much for PCRI's role in editing this and making this happen. Much appreciated to all of you. Thank you.